Our next talk is from Paul Baumann, who is the Chief Financial Officer for NHS England. He's been in the NHS for about 4 or 5 years, having been in the private sector at Unilever for many years. So, Paul.
Thank you very much, and welcome to this session on finance. It's never a good idea to compete with your chair, who is somewhere in another room at the moment telling people all the excitement about CSUs. So in that context, I'm delighted, I was going to say, to see so many of you here. I can't actually see you with the blinding light at the back, but I hope you can see me. So I'm going to deal in the next 20 minutes or so with the very simple challenge of ensuring that all 211 CCGs survive their first year of operation without actually going bust. Now, on the face of it, that shouldn't be an enormous challenge. We've got a great legacy coming through from the old system with a commissioning sector surplus for future investment of about £1.5 billion. All but one of the PCTs last year achieved balance or better as at the 31st of March. Many had created the recurrent financial headroom that they need to start investing behind their improvement priorities, as well as smoothing the way through all the lumps and bumps of transition. We have, according to reports, delivered the first 2 years of the 20 billion QIP savings challenge set by David Nicholson back in 2010, and all of that's been done at a time when there's been a clear, if not entirely universal trend of visible improvement in patient care across a wide range of performance, metrics and pathways. And that's a great tribute to the leadership of commissioning organisations over a period which has been real uncertainty and challenge for many. And of course the good news is that most of the current leaders of CCGs, and for that matter CSUs, have played a major role in all of this through their involvement in shadow boards and the like. So we don't actually start from scratch as of April the 1st. However, and this is a finance director's talk, so it always has to have a but quite early on in the speech, like the slightly iffy summer that we're all allegedly enjoying at the moment, there are quite a few storm clouds which are really going to impact on that otherwise very sunny picture. Firstly, you don't have to scratch very deep beneath the surface of the apparent financial balance in many PCTs to spot the increasingly ragged sticking plaster which holds all of that together and has done for some time. Some of it, it has to be said, borrowed from friends, family and neighbours around the patch. This is compounded, of course, in many health economies by real and increasing challenges in the provider sector, some of which are now reaching crisis point. The reforms themselves involve splitting up the commissioning sector and creating a clearer divide between providers and commissioners. And all of that is going to make management of emerging pressures significantly more complex than was previously the case. You wouldn't necessarily think it coming here today, but commissioners are having to face all of these challenges with significantly less resource than they had before. And as we all know, QIP to date, delivered as it has been heavily underpinned by short-term gains, and those opportunities are beginning to run out. Now, despite all of this, I do believe we can survive 2013-14 without going bust, but CCGs who are simply focused on achieving financial balance in the first year, as the title of this talk might suggest, are likely to fail in their rather more fundamental goal, which is, of course, not just to make ends meet, but to use the scarce taxpayers' fund entrusted to us to create high-quality care for all, right now and in a sustainable way for future generations. So, as the QIP sprint becomes a marathon, this is no time to get left behind. And since April, CCGs have already spent the best part of 13 billion, give or take the odd billion, and every penny counts. Now, as it is the title of the talk, I guess I need to say a few things about the basics of how to achieve balance in 13-14 before moving on to the rather wider issue of financial sustainability. We designed the planning framework in Everyone Counts that you'll all have been looking at in order to deliver an important balance between managing risk and stability in the first year whilst also maximising the funds available for patient care. As a health system, we can't afford to hold back large reserves to protect against all the possible problems and pressures during the year. There simply isn't enough money to do this, and even if there were, it's our job to get resources as quickly as possible to where they can make the biggest difference for patients, which is generally not the finance director's bottom drawer. So in order to strike this important balance, we established some rules of success for 13-14, where CCGs have been encouraged to do 3 fundamental things. The first is to build or sustain the cumulative surplus of 1%, which the average CCG will have inherited from its predecessor. The second is to set aside 2% of their annual allocation to fund one-off costs of transformation and to provide financial resilience for the future. And the third, no great excitement here, is to hold the contingency of at least 0.5% that we've had in the past as well. Now, the latest proposed plans submitted in May show that the CCG sector as a whole is broadly meeting these aspirations. But, more troublingly, about a quarter of CCGs are having real difficulty making ends meet, with little or no reserves to fall back on, in quite a number of cases also a significant underlying deficit to deal with. And there's clearly a risk in that context that a number of them will tip into the red if ambitious quit plans and activity reduction plans aren't delivered, or if problems in the wider health economies which they're responsible for make it impossible to make those required improvements. And in a year which seems to me to have more uncertainty than any other that I've faced in the NHS to date, or for that matter in the 20-odd years I spent in the private sector, there are few, if any, CCGs whose finances are so secure that they can afford to take their eye off the fiscal ball. So, what are we going to do about it? Unfortunately, there are no silver bullets. If you were hoping for the secret innovation which made it all possible to do that easily, you've come to the wrong lecture. So whichever end of the spectrum from rags to riches you inhabit, it all comes down, I'm afraid, to the basics. So at the risk of teaching quite a large mob of grandmothers to suck eggs, I just want to offer you 5 thoughts drawn largely from the bitter side of my personal experience, eventful experience, I would say, in the NHS to date. And the first comes straight from my recent involvement with a highly regarded PCT, which had fallen in record time from stardom to the failure regime. The circumstances, organisational transition, change of leadership, major shifting scope of commissioning, move to a new accounting system, emerging problems on the provider side, have for me at least an uncanny resonance with our current position across the health sector. And the key learning from that experience really is that past performance is no guarantee of future success at times of transition. Whether we're board members, finance directors, internal auditors or regulators, it's all too easy to rely on an apparently smooth track record without asking the really difficult questions about what's happening now. We can sometimes lose our sense of smell, if you like, and then ignore the mounting evidence that something's on fire. So we all need to work in this year above all with a presumption of heightened risk of failure. Not getting carried away with the rhetoric of light touch and liberty, relevant though those are, but instead making sure that the whole governing body, not just the hapless finance director, is keeping a vice-like grip on the detail, as well as maintaining a shared view of the big picture. I'd encourage you to think who in your organisation is going to be the one that has the nose to do the smelling, and the courage to press the fire alarm when needed. And this year, above all years, we simply don't have the luxury of having more than one version of the truth. Whether for internal reporting or in our accountability to the outside world, we've got to have a single version of the numbers and indeed of the wider performance. So that's the first point. Second point is that the planning process this year has highlighted the need for CCGs more than ever before to have a really deep understanding of the underlying recurrent financial position they've inherited. This might sound really obvious, but we've been surprisingly poor at this in the NHS to date. And our main financial metrics that we pride ourselves on, focusing on a cumulative surplus position, combining all of the achievements and failures of the past and present, and largely ignoring more immediate indicators such as cash, don't always make it easy to work out what's going on under the surface. So at its simplest, a CCG aiming for a surplus of 1% can be heading for greatness if they started out with nothing and have built the momentum to achieve that in year. Or they can be absolutely equally heading for the rocks if they started out with 5% of surplus and have used the 4% difference on things which carry a recurrent tail with them. And the differentiation between those two is paramount and has not always been clear. Now, as we went through a process of so-called deep dives into the most risky plans this year, we struggled in many cases to extract a clear and credible articulation of the underlying performance dynamics, stripping out previous external support and windfalls, adjusting for part-year effect of savings programs and investments, working out the real underlying trend in activity growth, and critically making that distinction between recurrent and non-recurrent spending. So if you haven't got that understanding right across your leadership team now, you really are flying blind. That's the second point. Thirdly, one of the curses of commissioning organisations is they don't actually have proper income lines, just an allocation of resource which can be built on assumptions and phased at will. And this has been a frequent source of problems where organisations have built their forecasts on hope of external salvation of one sort or another, or vague promises of future virtue on the spending front. But it's a particular source of complexity and challenge this year, as many of you will know all too well, because of the uncertainties around baselines related in particular to specialised commissioning. This is going to need real focus as we go through the year. We're all committed to taking this as a common problem of a start-up year. We just need to have real collaboration and cooperacy between the CCGs, between the NHS England area teams and the providers involved in all of this. If not, we will end up with a train crash, which we'll regret at our leisure. And then fourthly, there's the holy grail of QIP. Of course, QIP strategies, as we all know, need to be developed over medium-term timelines, not just as part of the annual planning process. The best QIP plans are collaborative, innovative, and designed across the whole health economy. And they must always be clinically driven, with a rigorous assessment of quality, impact, and deliverability. Now, people like me often get excited by the wide range of apparent ambition in QIP savings targets across the sector. As it happens, in the plans that we've got at the moment, they range from under 1% to over 5%, and the average just over 2.5%. But what really matters is whether they're aligned with strategic priorities, and at a much more basic level, whether the net activity growth trends which they imply are plausible and consistently reflected in contracts and plans across the health economy. If not, you can have the most elegant QIP plans in the world, the most strategically important ones, and you can have a world-class programme management office at your disposal, and all of those are important things, but they still have little chance of happening. And as the year progresses, this inevitably messy year, when changes in commissioning structures and the baseline uncertainties I mentioned just a moment or two ago are going to make comparisons of activity trends exceptionally difficult to monitor. We'll all need to invest time in spotting the wood from the trees in the activity statistics to enable us to intervene quickly when QIP schemes are going off plan. And finally, all of this suggests that we're going to need to develop some pretty clever solutions to uncertainty. What we don't need is massive reserves which generate the need for unrealistic savings assumptions, which in turn disrupt sensible capacity planning across the health economy, and, as the year progresses, lead inevitably, absolutely clearly so, to a loss of grip on what the real level of ambition was at the first place. What we do need is excellent, evidence-based and sensitive in-year forecasting, with honest and transparent risk and opportunity assessment. This is not something that's been a characteristic strength of many of our predecessor organisations. But given the choppy waters we're heading into, I really, really hope that CCGs and the CSUs that support them will ensure that they're equipped with world-class navigation tools before it's too late. And particularly given the disaggregation I talked about and the baselining issues we're all struggling with, many organisations will also conclude that they need to arrange some form of risk sharing alongside the ability to forecast the icebergs as we go along. There's no one right answer to this. It needs to suit the circumstances of the risk and the organisations concerned, and we're certainly not proposing to organise this centrally. But we've seen some great examples of collaborative risk-sharing approaches amongst CCGs and between NHS England and CCGs, ranging from relatively narrow collaboration on specific initiatives to full risk pooling of major services contracts. And I would commend to you all of those things as being the key things to keep your mind on as we go forward. In my judgment, surviving year one is possible, but for many CCGs, perhaps all CCGs, it's going to be a big challenge, and one in which none of us can afford to fail, because there's no second sitting of this particular exam. And it's not the only one, not the only challenge, or even the main challenge we've got to face. So as I turn now to planning for sustainability in the future, the answer seems to me to lie in seeing year one as the first year of a journey to building long-term financial sustainability, which simultaneously will enable the delivery of excellent patient care and the kind of transformational improvement in health outcomes that I hope you, as I did, have come to your jobs to deliver. This is the high-quality care for all now and for future generations, which I referred to earlier. Now, at national level, NHS England will be calling for open and transparent debate in what's being called the big conversation over the coming months to develop the strategy for the future. And I think CCGs need to be front and centre of those conversations with the local populations. You might question, some have, whether now, 2 months into a massive transition programme with more than enough to keep us busy, is the right time to launch such a programme. Well, I think it really matters. Together, we're responsible for a critical £96 billion industry, bigger than most national economies around the world, and one that's relied upon by every single person in the country. Doing that without a strategy is like flying a jumbo jet blindfolded and without the autopilot switched on. It's not going to be a happy journey. So I think that really matters. Second point is, we've now got the legitimacy to do a strategy. We, the CCGs, we, NHS England, we, the commissioners. We need to seize the legitimacy we get from being the voice of the patient, and we need to use the insights we get from that to shape the future of our service. And the way we're planning to do that is to set out over the next month or so a clear evidence-based case for change, showing why the current system is both clinically and financially unsustainable. Now, there's a really key point of principle here. Elsewhere in Europe, governments are solving this problem by variously cutting access to services, making people pay for them, drastically cutting the pay of health service employees, or pumping in money they haven't actually got. None of these is the way that we want to go. We are completely committed to retaining universal access to high-quality services, free for all and based on need. And it's already clear that the money is at best going to stand still for the next few years, and at worst will start becoming even tighter. So we need to unlock the most innovative and powerful ideas for squaring what seems to me like otherwise an impossible circle through our dialogue around the strategy. And then we'll support local communities to work together to incorporate them in their own plans in a way which creates vibrant health economies responding to the needs of their particular populations. So you might think, what's all this got to do with balancing in 1314? Well, the point is we can't wait for the end of that strategy process before we start putting things into action. Such financial flexibility as we've got will run out very quickly. So as I said earlier, every penny we spend in 1314 needs to count and needs to be directed towards those goals of changing the quality of things for patients. The starting point on strategic planning is at best patchy. PCTs really struggled with this, and outcomes from the CCG authorisation process in relation to planning-related conditions suggest there are still big challenges in this area. CCGs across the country found the planning criteria among the hardest to address, and the substantial group of CCGs that still have planning-related conditions are requiring significant levels of support in order to address them. So why is it so difficult, and what can we do about it? There are many challenges to focus on, but just a couple which I think are particularly relevant to my theme today. And while they're finance-focused, they're by no means limited to the finance community. Firstly, we need a step change in our capabilities in modelling. Too often, there's been a fatal dislocation between clinicians with great ideas and accountants with extensive spreadsheets of numbers which often appear to be for their personal entertainment. And transformation programmes have frequently been severely hampered by the lack of a shared understanding of financial dynamics between commissioners, providers, and indeed other local partners like social care, resulting in rival models and competing solutions. So I think we need to develop the art, or maybe it's a science, we can debate that a long time, of fusing together clinical and financial insights to model future scenarios in a compelling and evidence-based way. Models which span commissioning and provider impacts and have the clarity to support shared decision-making for the future. CCGs and their local partners need to own these, but there's also a clear role for CSUs to help develop and populate them. Second thing is, we need to ensure that we're getting the biggest bang for our buck on our investments and on our innovations. This is of paramount importance for different reasons, whether you've got a little or a lot to invest. Linking outcomes to investment is commonplace in most industries, but it's a particular challenge in healthcare, and one which, frankly, we've not really had to address with urgency in this time of plenty that we've had to date. I'm personally committed to helping to create a more rigorous approach to identifying and measuring the patient benefits resulting from investment. That's what value in the NHS is all about, and it's a key pillar of the work, for example, that we're doing on allocations going forward. But it's very much a long-term project. And again, we can't wait for the Holy Grail. The boldest innovators in other sectors are those who are slick at evaluating with the evidence they have available at any point in time. They evaluate, they set clear and immediate indicators of success, they quickly assess whether things are on track or not, and then they either promote them or kill them based on the emerging evidence. Now, CCGs with the support of CSUs are going to need to emulate those fast cycle innovation disciplines if they're going to have any chance of maximising the impact of the significant but ultimately finite capacity for investment that we've got, and in the process manage the risks of experimentation in a vital public sector needing to operate at pace, but which operates under what is often a very harsh spotlight. And it's not only about the new money, it's also about reshaping the whole pattern of health and indeed social care spending. It's about understanding the matrix of what and whom we spend it on currently. For example, by shining a clear light on the way that we care for the 5% of the population on which we currently spend nearly half of our combined money. It's about engaging with health and wellbeing boards, patients and other stakeholders to determine the future profile, the one that delivers the best possible outcomes from the limited resources available. And it's about working out how to migrate from A to B in a safe and affordable way. And again, we need to fall back on a much richer mix of evidence than we've had in the somewhat anecdotal approach we've often had to strategy in the past. Many of you will be aware that there's a substantial analytics team in NHS England who are currently developing tools for commissioners to help with the key questions on allocative efficiency, which is what all of this boils down to. A health investment network has been established to help commissioners improve their ability to achieve the best health outcomes for every pound invested. And to support this, the team is developing and bringing together a variety of tools, old and new, covering spend, activity, outcome comparison, bringing them together across a range of programs to contribute insight. Now, I know that many of you have already become involved in this work. There are already 200 members of that particular network. But I would suggest to you that all CCGs need to work with their CSUs and with these networks and central resources to make use of the tools and resources we've got as they become available and start creating the sustainable spend patterns across their health economies before the money runs out. So in conclusion, the race is on, the baton has been passed firmly and squarely to CCGs, and the course is, I'm afraid, getting tougher. Surviving 1314 is going to require great discipline, great professionalism, but above all, strong collaboration across the system. But the real challenge is taking the bold steps now to position ourselves well for a future in which we need to make every penny count for the patients and for the communities we're here to serve. And there I'd like to leave it. If you have any questions on any of that, I will be happy to address them.
Is my mic on? Yes. We've got a roving mic. If you want to ask Paul any questions, if you wave, it's quite difficult to see from up here with the lights. But anyone got any questions? Otherwise, I'm going to shamelessly abuse my position as chair and ask Paul. One of the biggest issues concerning CCGs at the moment, Paul, is the allocation adjustments to specialist commissioning. So in my CCG on the 1st of April, we had been authorised with no conditions. We had a robust plan involving transforming out-of-hospital care and addressing what is the worst life expectancy in the country. We had the required reserves and we were in a healthy position. 2 months later, we are posting a £7 million deficit, entirely related to the allocation adjustments to specialist commissioning. This is causing a lot of concern to a lot of CCGs. We are assured that this will be sorted out, but really there's still a degree of worry and concern about this. The further we get into the year, the greater that concern is, and really what we'd like is some assurance from you.
Well, the first assurance I can give is it's even more of a worry for me than it is for you, I think would be the first thing to say. This is a significant challenge that we've got. It's all related, of course, to the transition from one set of commissioners to another set of commissioners, the simultaneous change, if we think about it in specialised commissioning, in the scope of commissioning, the way in which we do it, provider base against population base, the policies we adopt, etc., etc. It's massively complex, and frankly, we've all been, I think, surprised by the difficulty there has been in getting that tied down. The key point, however, it's a shared problem. This is not a problem that's being dumped on one side or the other side of the CCG, NHS England divide, if you like, if there is such a divide. It's a shared problem. Together we've got to work as quickly as we can now. We're making quick progress, but we're still some way off it at the moment, to get plans which have a sensible balance, where we've got the resource as best we can estimate it in the right place to match the expenditure as we think it's going to fall. Equally importantly, the plan will be great. The plan will be, I'm sure, as good as we can make it. As the year progresses, we're going to have really robust mechanisms of seeing where the cost actually falls and then, frankly, moving the resource as appropriate to ensure that we don't get the kind of distorting impacts on QIP programs that you talked about earlier. So that's where we're at on it. And I'm absolutely committed to making sure that this doesn't become the thing which ruins individual people's plans or leaves us in major difficulties in 13-14, but it is a very big challenge as you suggest. The one reassuring thing is we haven't suddenly invented a whole other set of patients or a whole other set of treatments across the board. So the totality of this ought to be self-balancing. We're just struggling to make sure the balance falls in the right places.
Thank you. Any questions for Paul?
Hello. Hi, I'm Ian Mack. I'm chair of a CCG in Norfolk. One thing which has also changed and has a financial impact has been the approach to NHS continuing healthcare claims, and the fact this is now landed on our budget line. It's a historical cost, and it's one which is certainly causing difficulty to many CCGs which have large numbers of older people historically. So what are you doing to lobby on this? Because as I understand it, in at least the last year, the Department of Health actually sent £1 billion back to the Exchequer in terms of a surplus of total NHS costs within the UK. So what are you lobbying to do to make sure we get redress of this money, because that will derail a number of us as CCGs in this financial year?
So it's all caught up in discussion which we continue to have with the Department of Health around the balance of risks for this year. Now, in theory, and I hope in practice, a large part of the historic liabilities will have been covered by the provisions which have come across from the previous system. To the extent that isn't the case, we've got clearly a bigger exposure than that would imply. But again, it's a little bit like the specialised commissioning thing. I'm not seeing that as being something which we are simply dumping on individual organisations. It will be collaborative amongst us in the system. And as part of our shared risk management with the Department of Health, there is a very clear recognition that continuing healthcare will bring us some issues this year to deal with, which we will deal with in the round and make sure that that risk is managed together.
Any more? You'll have to wave because I just can't see. No. Okay, can we all thank Paul very much for coming to talk to us